there is outer ear, middle ear, and inner ear. For outer ear, you can see there is a structure that you can see it from outside. Is visible to anybody. That's called auricle. This area of the external ear or outer ear is called concha. Concha is connected to the external auditory meatus, which is a large opening, and from here to here is the external auditory canal. So this is meatus, this area, and the canal is the whole from here to here. External auditory canal is separated from the middle ear by this structure, and this is called the tympanic membrane. The middle ear is a cavity. It contains some ossicles. Ossicle means small bones. So these are three ossicles here: malleus, incus, and stapes. Malleus is connected to the tympanic membrane. Incus is connecting malleus with stapes, and stapes is connected to an area is called oval window, and that is oval window separating inner ear from the middle ear. The middle ear cavity is also connected to pharynx, so this is called pharyngotympanic tube or eustachian tube. And sometimes this area is blocked, and this is why when you travel there is a change in the pressure, and this is why you get ear pain. And if you chew something or if you yawn something, this area opens up and the pressure on both sides balance out, and the pain usually decrease. There is another area, this is called the round window. This thing that you see, this is also an area that's separating the middle ear from the inner ear. So the inner ear is made of two parts. One is called cochlea, and this is responsible for hearing, and another area that is for balance. So for balance there is two different areas. One is called the vestibule. You can put an arrow there, and the other part is called semicircular canals. So once again, semicircular canals, which is this area, and the vestibule, they are both part of the inner ear, which is responsible for balance. The other part of the ear, inner ear, is called cochlea or cochlea. Both of them are correct pronunciation, and that is for hearing. So for abstraction, usually it can be a foreign body. Wax is although the most common cause, and when people are cleaning their ear, they are trying cleaning it. Some people are pushing the wax more deeply, and that's why it creates it makes the wax harder, and that's why it blocks the external auditory canal and makes the hearing more difficult. This is easy to treat, so just remove the wax or remove the foreign body. It's easy to treat. Another condition is called otosclerosis, and in the otosclerosis it's a progressive hearing loss. This is the cause is not known. It happens in young to middle-aged adults, and the ossicles fuse together. There's a lot of fibrosis formed there, and the person cannot hear anything. So it is it's a common cause of the progressive hearing loss. The obstruction usually happens faster, but this is a progressive hearing loss. And otitis media is common in young children, so usually between age 1 and 3. This is very, very common. Some of you may have had that. So this can be a viral infection, or it can be a bacterial infection. Bacterial infection is of course more serious, and pus forms inside the middle ear that may cause meningitis or it may cause brain abscess. Both of them are very, very serious conditions. And for viral infection, you just have to wait and it goes away. You can give some medication for pain, but for the bacterial otitis media, you have to give antibiotics because you want to prevent complications. Sometimes the tympanic membrane ruptures and the pus is coming out of the ear, so it's a common condition. If a child is crying a lot, is very irritated, and pulling the auricle upward, the area is red behind the ear, so that's likely the person may have otitis media. So now let's talk about hearing. For hearing, is cochlea is involved. If you cut the cochlea, you can get something like this. So this whole area that you can see where the arrow is pointing to, that is called bony labyrinth. Bony labyrinth. So this is like a wall made of bones, and this is a part of the tympanic bone inside temporal bone, and that is wall of the cochlea. So another structure is called membranous labyrinth. So this is the membranous labyrinth. If you look at it, the bony labyrinth is made of the vestibular duct and the tympanic duct, and the membranous labyrinth is made of the cochlear duct. The membranous labyrinth is separated from the tympanic duct by the basilar membrane, and on top of the basilar membrane inside the cochlear duct you have hair cells, and that is connected to a nerve, and the cell bodies of those nerve fibers are located in the spiral ganglia. The image below, if you look at it, so this is the start of the oval window. So this is the stapes. Stapes should be here. So this is a little bit mistake in this image. Stapes should be here, and the oval window is separating the middle ear from the inner ear. So the beginning of the vestibular duct is starting from the oval window, and there is a fluid there, and that fluid is called perilymph. It goes all the way to the tip of the cochlea, so this area, and that is called helicotrema, and then it continues with the tympanic duct. Tympanic duct also contains perilymph, and then the tympanic duct ends with a round window, and round window is this area, and that separates the inner ear from the middle ear, which is around this area. This is the histology of the bony and membranous labyrinth. So this area, this whole area, as you can see, is the bone. This is part of the cochlea, and this is the vestibular duct, starting from the oval window, and contains perilymph. Then it goes all the way to the apex, and then it changes and becomes the tympanic duct, and this also contains the perilymph. In the middle you have the cochlear duct, and you can see these two membranes. These are made of connective tissue and epithelial tissue, so this is why it's called membranous labyrinth. This area contains endolymph, which is a little bit different here. Hair cells are located here in the basilar membrane, and these are the nerve fibers, and it goes all the way to here, and the cell bodies are in the spiral ganglion. So spiral ganglion contains afferent cell bodies that are coming from the hair cells in the basilar membrane. Okay, so this shows a little bit higher zoom of the cochlear duct here. This area is called hysteria vascularis, so it's very vascular. A lot of blood vessels are there, and the potassium is leaving the blood and is concentrating in endolymph. So endolymph contains a lot of potassium. This membrane that you see here, this is called the Reisner membrane. Another more common name for that is called vestibular membrane, and that is separating the vestibular duct from the cochlear duct. This area that you see, this is the basilar membrane. So the basilar membrane is separating the tympanic duct from the cochlear duct. And the basilar membrane contains hair cells. So this is the hair cells. These are called outer hair cells, and this is important for amplification and fine-tuning of different sounds. And this is the inner hair cells, and this is important for processing sound. So if the sound is lower, then the outer hair cells can amplify that sound. And this is the tectorial membrane. I have a different image for that, and that you can see later, and that is embedded, the outer hair cells are embedded in the tectorial membrane. Nerve fibers are here, and from the outer and inner hair cells, and then goes through, and that creates part of the cranial nerve 8. So cranial nerve 8 has two divisions. One is the cochlear division, that is for hearing, and the other one is the vestibular division, which is for balance. So this is how the sound transmits and is processed. So auricle is responsible for picking up the sound and concentrating it and putting it into the external auditory canal, and then when the sounds here is highly concentrated and it hits the tympanic membrane, it moves the tympanic membrane, and this movement will cause what? Cause movement of these three ossicles. So malleus first, incus, and then stapes. So because malleus is bigger and then the stapes is smaller, so that will cause amplification of the sound. The stapes is connected to the oval window. So this image is actually the correct image. The couple of slides ago that was incorrect, because it shows showing stapes is here, but it's not there. So stapes should be in the beginning of the vestibular duct. So vestibular duct contains fluid. Now when the sound comes, the stapes pushes in, and when it pushes in, it moves the fluid, so increase the pressure here in the vestibular duct. As the pressure increases in the vestibular duct, then depends on the frequency of the sound, the cochlear duct also moves, and that will also cause changes in the movement of fluid in the tympanic duct, because they are connected. As you can see here, the vestibular duct is connected to the tympanic duct, so that's why when a higher pressure here, then that pressure goes to this area. Pressure always goes from higher area to the lower area, so that's the pressure gradient. So when the pressure comes and the fluid moves this way, the fluid waves, it will push the round window. So now the round window bulges into the middle ear. So once again, when you hear a sound, the oval window pushes into the vestibular duct, fluid moves, and when the fluid comes back, now the round window bulges into the middle ear cavity. The fluid does not drain there, it's just bulging out. And you can also see that you can have the cochlear duct, and the cochlear duct contains organ of Corti, which we will talk about it. So this is the area that hair cells are located, and then you can see these nerve fibers are located and coming from those hair cells in the cochlear duct, and it goes to the spiral ganglia. So if there's a high frequency sound, usually these areas are stimulated. So these areas of the cochlear duct and the hair cells are stimulated, and if it is a lower frequency, usually the tip of the apex is stimulated, so the nerve fibers here are stimulated. So this is the organ of Corti. So you can see this is the cochlear duct, so made filled with endolymph that contains a lot of potassium, and the cochlear duct is separated from the vestibular duct by the vestibular membrane here, and the cochlear duct is separated from the tympanic duct by the basilar membrane. On top of the basal membrane you have these hair cells, and these are the supporting cells. There's two types of hair cells. One is the outer hair cells and the other one is inner hair cells. The inner hair cells do not directly connect with the tectorial membrane, but the outer hair cells are close in contact with the tectorial membrane. So when the fluid moves and it comes through the tympanic duct, this basilar membrane goes up and down, and these hair cells, stimulated by the tectorial membrane, and then is stimulating the nerve fibers. And the fluid also moves in the cochlear duct, so that's why the inner hair cells are also stimulated and send signal to the brainstem through the spiral ganglion. This image, you can see that the nerve fibers, majority of the nerve fibers are leaving the hair cells, and these are the afferent cells, and that makes the majority of the cochlear nerve. So many of those nerve fibers are coming from inner hair cells. Some of them are coming from the outer hair cells, and these are afferent, so this is for processing sound. But there is also another mechanism. These are the efferent ones that are going to the outer hair cells, and they are inhibiting the response of the outer hair cells when the fluid, when waves comes, the basilar membrane moves, and also the tectorial membrane moves. So that reduces the amplification of the sounds that happens by the outer hair cells. So majority of the cochlear nerve contains afferent nerves toward the brainstem, but some of them are coming from brainstem. So this slide shows the physiology of hair cells. These are specialized epithelial cells, and they have microvilli. These are called stereocilia. This is a spelling. Stereocilium is a singular form. Stereocilia is the plural form. Kinocilium is the longest of those microvilli, and you can see these proteins that are connecting the tips of these stereocilia. In the tips you can see that potassium channels are there. So normally if there is a movement of the kinocilium toward the rest of the stereocilia, nothing will happen. So this is the hyperpolarization. But if these stereocilium moves toward the kinocilium, then the tip links proteins are stretched out. When they are stretched out, then because they are attached to the potassium channels, they open up the potassium channels, and inside the cochlear duct there's a lot of potassium there. So these potassium ions enter the stereocilia and enters the hair cells. So potassium is positively charged, and that will cause depolarization. Normally sodium enters the cell, and that will cause depolarization. Potassium leaves the cell, but this is an exception there. Because of the depolarization, calciums enter now the cell, and if you remember, calcium is important for fusion of the vesicles to the plasma membrane of the cells, and then these vesicles contains glutamate, that's the neurotransmitter, and that will cause exocytosis, and the postsynaptic membrane here is picking up, and then it will cause activation of the nerves here, and then that's how a person hears sound. So this is a spiral ganglion. That is the one that the cell bodies of these afferent nerves are located there, and that is coming from the hair cells. Cell bodies here, and then that is in the cochlea. So then the fibers are going to the brainstem. So this is the cochlear nuclei are located. This is the location of the cochlear nuclei. The cochlear nuclei is located in the rostral medulla and in the caudal pons. So this is the pons. So this is the area that is, the cochlear nuclei are located, and that process the information, and then it crosses the midline and goes to the inferior colliculus. So the fibers here are called lateral lemniscus, and if you guys remember, there was also medial lemniscus, and that was responsible for movement of the eye. So this lateral lemniscus, it goes to the inferior colliculus. Inferior colliculus, if you remember, it was in the midbrain. So from there it goes to the medial geniculate nucleus, and the fibers here is called inferior brachium. The medial geniculate nucleus is located in the thalamus. From there it goes to the transverse temporal gyrus in the cortex of brain, and the information is processed there. And depends on the frequency of the sound, it goes to different areas. It's not shown here, but it goes to different areas in the transverse temporal gyrus. So some causes of hearing loss. So this is also called sensorineural hearing loss. There can be drugs and toxins, so quinine, aspirin, and streptomycin, some of them. Prolonged exposure to the loud noise, for example, hearing to my lecture, that can be a prolonged exposure. And instead of that, you can listen to Carby B songs, so she can sing better, so that will not cause any damage to your hearing sensation. Infections like rubella and during pregnancy, cytomegalovirus and syphilis can cause nerve deafness. Probably the most common cause of the nerve deafness is called presbycusis, and that is happening with age. So as the person gets older, so they lose some of the hair cells, and that will cause nerve deafness. And also tumor, which is not that common, and that is the tumor, benign tumor of Schwann cells, and that will cause unilateral deafness, tinnitus. It may compress the facial nerve, because the facial nerve also passes through very close to that, and they may also get some muscle weakness on the face. Sometimes they get pain in that area, so it sometimes for diagnostic purposes it's a little bit difficult. You don't know, is it acoustic neuroma, or is it a problem from the cranial nerve 7, so you have to do some MRI to know which one it is.